Obstructive sleep apnea hypopnea represents one of the most prevalent yet underdiagnosed sleep disorders affecting millions of individuals worldwide. This complex respiratory condition occurs when the upper airway becomes partially or completely blocked during sleep, leading to interrupted breathing patterns that can profoundly impact both immediate sleep quality and long-term health outcomes. The disorder encompasses two primary components: apneas, which are complete cessations of airflow lasting 10 seconds or longer, and hypopneas, which involve significant reductions in airflow accompanied by oxygen desaturation or arousal from sleep. The pathophysiology of obstructive sleep apnea hypopnea involves intricate interactions between anatomical predispositions and physiological mechanisms. During sleep, the muscles supporting the throat and tongue naturally relax, but in individuals with this condition, this relaxation becomes excessive, causing the soft tissues to collapse and obstruct the airway. The tongue may fall backward, the soft palate may sag, or enlarged tonsils and adenoids may contribute to the blockage. When breathing becomes compromised, oxygen levels in the blood decrease, triggering the brain to briefly awaken the individual to restore normal breathing. These micro-awakenings, often lasting only seconds and remaining unremembered by the patient, can occur hundreds of times throughout a single night, severely fragmenting sleep architecture and preventing the restorative stages of deep sleep. Risk factors for developing obstructive sleep apnea hypopnea are numerous and varied, encompassing both modifiable and non-modifiable elements. Obesity stands as the most significant risk factor, as excess weight, particularly around the neck and throat area, increases the likelihood of airway obstruction. Age plays a crucial role, with the condition becoming more prevalent as individuals grow older due to natural changes in muscle tone and tissue elasticity. Gender differences are notable, with men being 2 to 3 times more likely to develop the condition than women, though postmenopausal women experience increased risk. Anatomical factors such as a narrow airway, enlarged tongue or tonsils, deviated nasal septum, or receding chin can predispose individuals to airway collapse. Additionally, lifestyle factors including alcohol consumption, smoking, and sedative use can exacerbate the condition by further relaxing throat muscles or increasing inflammation in the airways. The clinical presentation of obstructive sleep apnea hypopnea extends far beyond simple snoring, encompassing a constellation of symptoms that affect both nighttime and daytime functioning. Loud, persistent snoring punctuated by periods of silence followed by gasping or choking sounds represents the most recognizable symptom, often first noticed by bed partners. Patients frequently experience restless sleep, frequent awakenings, and morning headaches due to overnight oxygen deprivation and carbon dioxide retention. Daytime symptoms are equally concerning and include excessive daytime sleepiness, difficulty concentrating, memory problems, irritability, and mood changes including depression and anxiety. The cognitive impairment associated with sleep fragmentation can significantly impact work performance, academic achievement, and overall quality of life, while the persistent fatigue increases the risk of accidents, particularly motor vehicle crashes. Diagnosis of obstructive sleep apnea hypopnea requires comprehensive evaluation combining clinical assessment with objective sleep studies. The diagnostic process typically begins with a detailed medical history focusing on sleep patterns, symptoms, and risk factors, followed by physical examination of the upper airway, neck circumference measurement, and assessment of anatomical features. The gold standard for diagnosis remains overnight polysomnography, conducted in a sleep laboratory under professional supervision. This comprehensive study monitors multiple physiological parameters including brain waves, eye movements, muscle activity, heart rhythm, breathing patterns, and oxygen saturation levels. The apnea-hypopnea index, calculated as the total number of apneas and hypopneas per hour of sleep, serves as the primary metric for diagnosis and severity classification. Mild obstructive sleep apnea hypopnea is defined as 5 to 15 events per hour, moderate as 15 to 30 events per hour, and severe as more than 30 events per hour. Home sleep apnea testing has emerged as an alternative diagnostic approach for patients with high clinical suspicion and no significant comorbidities. These portable monitoring devices, while less comprehensive than full polysomnography, can effectively detect breathing disruptions and oxygen desaturation patterns in the home environment. However, they may underestimate the severity of the condition as they cannot account for sleep fragmentation and arousal patterns that require electroencephalographic monitoring. Treatment approaches for obstructive sleep apnea hypopnea are multifaceted and tailored to individual patient characteristics, severity of the condition, and underlying contributing factors. Continuous positive airway pressure therapy remains the first-line treatment for moderate to severe cases, delivering pressurized air through a mask to maintain airway patency throughout the night. Despite its effectiveness, CPAP therapy faces challenges with patient adherence, with compliance rates varying significantly due to mask discomfort, air pressure intolerance, and lifestyle factors. Alternative positive airway pressure modalities, including bilevel positive airway pressure and automatic positive airway pressure devices, may improve tolerance for some patients by providing variable pressure support or more comfortable pressure profiles. Oral appliance therapy represents an important treatment alternative, particularly for patients with mild to moderate obstructive sleep apnea hypopnea or those unable to tolerate CPAP therapy. These custom-fitted devices work by repositioning the jaw and tongue to maintain airway openness during sleep. Mandibular advancement devices, the most common type, hold the lower jaw in a forward position, while tongue-retaining devices prevent the tongue from falling backward and obstructing the airway. Surgical interventions may be considered when conservative treatments prove inadequate or inappropriate. Surgical options range from relatively minor procedures targeting specific anatomical abnormalities to more extensive reconstructive surgeries. Uvulopalato-pharyngoplasty involves removing excess tissue from the throat, while more advanced procedures like maxillomandibular advancement surgically reposition the upper and lower jaws to enlarge the airway space. The success of surgical treatment depends heavily on careful patient selection and identification of specific anatomical contributing factors. Lifestyle modifications play a crucial supporting role in managing obstructive sleep apnea hypopnea and may be sufficient for mild cases or serve as adjunctive therapy for more severe presentations. Weight loss, when applicable, can dramatically improve or even resolve the condition, as reducing excess tissue around the airway decreases obstruction risk. Sleep position therapy, encouraging side sleeping rather than supine positioning, can help prevent gravity-induced airway collapse. Avoiding alcohol and sedatives, particularly in the hours before bedtime, reduces muscle relaxation that contributes to airway obstruction. Smoking cessation decreases airway inflammation and improves overall respiratory health. The long-term health consequences of untreated obstructive sleep apnea hypopnea extend far beyond sleep disruption, encompassing cardiovascular, metabolic, and neurological complications. The repeated episodes of oxygen desaturation and arousal create significant physiological stress, leading to increased blood pressure, irregular heart rhythms, and elevated risk of heart disease and stroke. The condition is strongly associated with insulin resistance and type 2 diabetes, creating a complex interplay between sleep disorders and metabolic dysfunction. Cognitive effects include increased risk of dementia and accelerated cognitive decline, while mood disorders and decreased immune function further compromise overall health and well-being. Recognition and appropriate management of obstructive sleep apnea hypopnea represent critical components of comprehensive healthcare, requiring coordination between sleep medicine specialists, primary care providers, and other healthcare professionals. Early identification and treatment can dramatically improve quality of life, reduce health risks, and restore the restorative power of healthy sleep, emphasizing the importance of awareness and proactive screening for this common yet serious sleep disorder.